Hello friends, hi, I'm Dr. Shonali Chandra and I welcome you all to our YouTube channel Medicine Decoded. And in the line of series that I've started with the case scenarios, before I go on to discussing the case scenario of a molar pregnancy, I would like to just talk in brief about what exactly is a molar pregnancy. So to begin with, molar pregnancy belongs to a group of disorders which we call as the gestational trophoblastic diseases. So they are histopathologically originating from the trophoblastic tissue in and around of pregnancy. So gestational trophoblastic diseases which are a result of abnormal proliferation of placental trophoblasts. Now, these gestational trophoblastic diseases can be categorized into two groups. One is the benign, which includes your molar pregnancy, the complete mole and the partial mole, and the other is the malignant form of gestational trophoblastic diseases, which we call gestational trophoblastic neoplasia or GTN, which includes invasive mole being most common, so top of the list. Second most common, choriocarcinoma, placental trophoblastic tumor and endothelial trophoblastic tumor. The last two ones are extremely rare. So what is important to note here is that these malignant forms of gestational trophoblastic diseases, that is GTN, they can develop after any pregnancy event, be it after an abortion, molar pregnancy, ectopic pregnancy, full-term pregnancy event, irrespective of the outcome of that pregnancy. It can develop after any pregnancy event. But most commonly, gestational trophoblastic neoplasia is seen to arise or develop following a molar pregnancy event. So let us now in this session talk a little bit more about what exactly is a molar pregnancy. So we have two types of moles, I told you, complete mole and partial mole. Now note here that these complete mole on the left and we have partial mole on the right here, and these two kinds of molar pregnancy basically differs in their gross appearances, right? They also differ in their karyotype and they also differ on their histopathological examination findings, right? So as you can see grossly, if you can see, this is the gross picture. The complete mole, as you can see, is containing only of chorionic villi with no fetal or embryonic tissue present at all, right? So the fetal or embryonic tissue in a complete mole is absent, whereas in a partial mole, fetal or embryonic tissue, and this fetus is going to be a triploid. This fetus is going to be having triploid karyotype, therefore it will probably be dead or showing stigmata of these chromosomal abnormalities. So fetal or embryonic tissue is present in a partial mole. On the other hand, you can see that the hydropic swelling of the chorionic villi, there is extensive proliferation of chorionic villi only, that is a trophoblastic tissue only. So this hydropic swelling of chorionic tissue is diffuse in a case of complete mole, and this swelling of chorionic villi is seen in parts, in places in partial mole. So it is focal and not diffuse. All right, so that is another set of difference, and that can give rise to a cystic placenta here. So we can see a cystic placenta here. Okay, now the trophoblastic proliferation in a case of complete mole is also diffuse. The trophoblastic proliferation in a partial mole is focal, and vascularity of the villi. Now the vascularity of the villi is basically because of the fetal vessels which are traversing or traveling in the chorionic villi, right? Now the complete mole has no fetal tissue at all, so the vascularity is absent in a case of complete mole, whereas your partial mole, the vascularity is going to be present focally. So some areas of these chorionic villi are going to be vascular. So this is the basic set of differences as far as the gross and histopath is concerned regarding complete mole and partial mole, which you should remember, right? Now, let's have a look at the karyotype also of the two kinds of molar pregnancies. And for that, we'll first have to see how molar pregnancies are occurring. Okay. Now, molar pregnancies, to begin with, I also told you they are because of chromosomally abnormal fertilizations, right? Now, what does that mean? So, look at the figure on the left here. I'm showing you how a complete mole develops. So, it happens so that at times, and especially in extremes of maternal age, I mean adolescent pregnancy or advanced maternal age, there is a possibility that during the development of the oocyte, the egg turns out to be empty of its nuclear material. So we have here an empty egg that's get fertilized by a single sperm. Okay. Now, the sperm is haploid and the egg is empty. Now, when that happens after fertilization, the paternal DNA material or the paternal chromosomal constituent, it duplicates, resulting in a final diploid organism. But understand that this diploid zygote or this diploid conceptus does not have any maternal DNA. Maternal nuclear material isn't there. So this is abnormal, right? So it is an abnormal fertilization. Diploid, yes, true, but the genetic material of the mother is not there, right? So this kind of, molar pregnancy that happens is called as a complete mole, which is diploid in nature. Mostly they are monospermic. Mostly monospermic. That means a single sperm fertilizes an empty egg. About 20% of the times, it can be dispermic also. That means there will be an empty egg which get fertilized by two sperms. Maybe X, right? X component or X chromosome containing sperm, and that gives rise to a diploid conceptus, but without any maternal DNA. So it could be dispermic. It could be for X, Y here. It could be X containing sperm, Y containing sperm fertilizing, then this would become 46XY. It could be both Y containing sperms, then this would be 46YY. So this is the kind of permutation combination that can happen, and the most common karyotype in a case of complete mole is 46XX. This is also an often asked question in your examination, repeatedly asked. Now, what happens in a partial mole on the other? As you can see, partial mole are triploid. So what happens is the egg is not empty, right? The egg contains its chromosomal material and dispermy happens. That means two sperms fertilize the egg and that results in a triploid. Can you see now? So two sperms fertilize an egg and that results in a triploid conceptus. So triploid cells, maternal and paternal chromosomes are both present, and the extra material, the extra genetic material is coming from the father, is coming from the sperms. So this is how chromosomally abnormal fertilizations lead to two distinct kind of molar pregnancies, which is a complete mole and a partial mole. Now, let us just summarize here. So now let us just summarize the important points once and for all. Complete mole, diploid, partial mole, triploid, ploidy status, that is given to you, right? Monospermic or dispermic? Look at it here. Complete mole are mostly monospermic. 80% of the times they are monospermic. Single sperm fertilizes and then sperm DNA duplicates. And only 20% of the times they can be dispermic as well. Whereas your partial mole, on the other hand, monospermic or dispermic, they're always dispermic because they have to become triploid, so they're always dispermic, right? Now, what about the genetic material? The genetic material inside a complete mole, the entire material is paternal. The entire material is paternal. And what about the genetic material of triploid? The extra material is paternal in a case of partial mole. And maternal DNA material, maternal nuclear material is also present. Maternal nuclear material is also present. Now let us also elaborate one very important point about P57 KIP2 immunostaining. Well, to be very precise here, let's understand this like this. If you have to differentiate between complete mole and partial mole, right, and in clinics you have to do, in routine clinical practice, you would go ahead by ascertaining the, clinical features, and sometimes maybe, obviously the gross appearance will give you an idea. And finally, of course, your diagnosis can be confirmed by histopathological evaluation. Now, let's say on histopath also maybe sometimes you can have a doubt in coming to the diagnosis of a partial mole versus a complete mole. Then in those circumstances, one can use other tests like ploidy status. You could check the material for the ploidy status, check the karyotype of the material that has been evacuated from these molar pregnancies, and also the P57 KIP2 immunostaining. Now this P57 KIP2, this is a gene product, right? It comes from the P57 KIP2 gene. Now remember, go back to your basics and understand, if you've read about this genomic imprinting, you see all of us inherit certain genes, and some of the genes, may be paternally expressed, may be maternally expressed. The maternal component that we have inherited may be expressed, or the paternal component that we have inherited may be expressed. So by that, taking that analogy further, you see the P57 KIP2 gene is paternally silenced and only expressed the maternal side of the gene. So maternally which we inherit, that is expressed. So P57 KIP2 gene is paternally silenced. That means it is only expressed by the maternally inherited component. Now, this complete mole has no maternal DNA, genetic component. All the material is paternal. This gene is paternally silenced. Maternal DNA is not there, right? So what will happen? The P57 KIP2's immunostaining will be negative. That's the logic. Whereas in partial mole, though it is paternally silenced, this gene product is paternally silenced, but the maternal DNA is there, and this gene is maternally expressed, paternally silenced, and maternally expressed. So P57 KIP2 immunostaining is positive. Now that's the logic. A simple trick to remember would be the P. P for partial mole, right? P for P57 KIP2 immunostaining. P for positive in partial mole. That's a trick to remember this important information. The logic I have explained to you. Now, moving on further, we shall also talk about the clinical presentation. Now, the clinical presentation of a molar pregnancy, as you can see, now we just talked about what molar pregnancy exactly is. And as you can see that they are chromosomally abnormal fertilizations, they have no future, right? So they would not progress. They would end up, they would not grow too much. The pregnancy would not continue till the term, obviously. So what does it present with? It presents with vaginal bleeding. Right? And vaginal bleeding in which trimester? It can happen anytime in the first or second trimester, but most commonly this vaginal bleeding happens in the first trimester. Right? And many times what happens is that these chorionic villi which are filling the uterine cavity, you see, they can separate from the decidua, and blood can also get collected inside, and extensive proliferation of the chorionic villi plus collection of some blood inside, it leads to enlarged uterus. So there is excessive enlargement of the uterus, right? So complete molar pregnancies are usually, mind you, or let's say in half of the cases, associated with an enlarged uterus more than the period of gestation. So uterus enlarged more than the period of gestation in about 50% of the cases. That means in the remaining set of the cases, the size of the uterus could be equal or even smaller than the period of gestation. So usually more than the period of gestation, but could be the same size or smaller as well. Now, when a woman complains of bleeding in a case of molar pregnancy, the bleeding can be frank bright red bleeding, or the bleeding could be just in the form of an altered brown discharge or spotting, or sometimes even the woman might give a history of passage of grape-like vesicles. Those hydropically distended chorionic villi, they give the appearance of grape-like vesicles. So passage of those vesicles could be appreciated by the woman, and she could give you that history. And other than that, there's excessive nausea and vomiting. Now, these extensively proliferated chorionic villi, they produce excessive amounts of beta HCG. Excessive amounts of beta HCG are produced. Now, in complete mole, the beta HCG is usually more than 10 to the power 5 international units per liter, and in partial mole, it's usually less than 10 to the power of 5 international units per liter. But having said that, the levels of beta HCG are always going to be more than the normal intrauterine pregnancy at that gestation, right? So excessive beta HCG is responsible for a whole constellation of symptoms pertaining to molar pregnancy. One of them is excessive nausea and vomiting. Now, what are the other clinical presentations? So other the clinical presentations can also happen, and these other clinical presentations or associated clinical conditions, they are much more common in complete mole as compared to partial mole. They are more in complete mole as compared to partial mole. They're in fact very rare in partial mole to begin with. So hyperemesis, that nausea and vomiting, can progress to a state where it becomes absolutely intolerable for the woman to eat at all, and can lead to dehydration and the other complications of hyperemesis gravidarum. And you can have early onset preeclampsia. I mean, preeclampsia usually begins after 20 weeks of gestation, picked up by that. If the features of preeclampsia like hypertension, right, like proteinuria, like end organ involvement, if early onset features of preeclampsia are occurring, we could suspect a molar pregnancy. So early onset preeclampsia. Hyperthyroidism. Now, hyperthyroidism is also not seen in all the cases of molar pregnancy, but yes, about 7 to 10% cases of Molar pregnancy, complete molar pregnancy can show hyperthyroidism. Now this beta HCG, you see the HCG is biochemically, structurally similar to the TSH hormone, thyroid stimulating hormone, and can then stimulate the maternal thyroid gland to secrete more thyroid hormones, leading to symptoms of hyperthyroidism, like there could be tachycardia, like there could be tremors, like there could be warm skin, right? So this should be important to note. So think about it, if there is a tachycardia in a woman with molar pregnancy, you see, and that tachycardia is out of proportion to the visible bleeding, the tachycardia is out of proportion to any, and there's no fever, right? Then think of the possibility of hyperthyroidism associated with molar pregnancy as well. Then of course there can be pulmonary edema, again a rare complication, rare association with molar pregnancy, but you should know that pulmonary edema can happen. Well, what can happen is these grape-like vesicles, these chorionic villi, they can disseminate into the venous circulation, from the uterine veins to the internal iliac veins, and then to the venous system of the mother, and then to the lungs, and then can they cause pulmonary emboli. All right, so pulmonary emboli can then lead to pulmonary edema. So this can be a complication of molar pregnancy, but then again it's not that common and rare. And then you can have theca lutein cyst. Now this beta HCG also acts like the LH hormone, structurally similar to LH hormone, and then because of that action similarity, it can stimulate the theca cells of the ovarian follicles and make them grow, right? So that can lead to theca lutein cyst formation in ovaries. Usually they are bilateral, right? So bilateral theca lutein ovarian cysts, these are ovarian cysts, again happening because of excessive beta HCG stimulation to the ovaries. Right now, other than this, also keep in mind another important dictum I want to give it to you, that if there is a case of complete or any molar pregnancy for that matter, because I'm writing complete molar pregnancy because these medical associations are in any ways rare in a case of partial mole. That's why I'm writing complete molar pregnancy. If a patient of complete molar pregnancy has respiratory distress also, what are you going to think? You're going to think possibly pulmonary edema, but pulmonary edema, I likely told you, is rare. So respiratory distress in the case of complete molar pregnancy could be because of, think the commoner things first. Think the possibility of preeclampsia. Think about the possibility of early onset preeclampsia. Think about the possibility of a thyroid storm. Think about the possibility of pulmonary embolism also. So do not forget that a woman with complete molar pregnancy, if she's having difficulty breathing, breathlessness, it could also be because of early onset preeclampsia. She could be having a thyroid storm and pulmonary embolism. Now, why am I emphasizing on thyroid storm so much? I'm telling you that it happens in about 8 to 10% of cases, or 7 to 10% of cases, but I am emphasizing on you to remember this and keep this in mind, because it is of imperative importance for anesthesia, right? So if you take up a patient on table, maybe for, if you have to manage a molar pregnancy and you have to evacuate the uterus and you have to give the patient some or the other form of anesthesia, regional anesthesia or a general anesthesia or any other drug, you see, then if you give that to a thyroid storm patient on table, that can be disastrous. The patient could suffer from cardiac arrest, right? So you need to be aware of this possibility. Keep your mind open, and if the features are there, then make sure that you check for the thyroid levels. Okay, you check for the thyroid profile of the woman to see if she's in a thyroid storm or not, right? And usually also complications like preeclampsia, hyperthyroidism, pulmonary edema, and all these things. Such medical complications happen when the uterus is excessively enlarged, usually more than 16 weeks in size, with a very high beta HCG level, right? So generally, those are the clues which will make you suspect, there could be a possibility of these medical complications as well. So now with this video, we have discussed what is a molar pregnancy. All right, it begins from a simple benign gestational trophoblastic disease. Yes, it can, progress to a gestational trophoblastic neoplasia, but how it happens or when it happens is a topic for another discussion. In this video, we've particularly discussed the two types of benign molar pregnancies, complete mole versus partial mole, and we have taken and discussed the clinical presentation of the molar pregnancy. And in my next video, watch out for the clinical case scenario, and then we'll discuss the investigations, the workup, and the management of a molar pregnancy. So thank you so much for listening. Have a great day.